Hi, everybody. Dr. Demito here. We're going to talk about Chapter 3 of your text today, and this refers to examination techniques and equipment. This course is really important. You need to have a good grasp on techniques and equipment once you're in the practicum setting so that you can feel confident in what you're doing, and also it will help guide you as to your differential diagnosis and other examination techniques and testing that may be necessary. Now, some of these techniques I'm incredibly familiar with after having a career nursing in excess of 30 years. Others I've barely interacted with, so it's a good idea to have a strong understanding of the most commonly used examination techniques, be able to perform them well, and you're definitely going to impress your preceptor. So let's go ahead and move. Now, the first thing I always tell students that when the first thing I do in an examination is to identify subjective and objective data. And you'll need this for SOAP note charting as well. The S on a SOAP note is subjective and the O in the SOAP note is objective. So you need to have a clear understanding of what's the difference between the two of them. And I find lots of students struggle with this. Subjective information is what the patient tells you. Objective data is what you see. So anything that the patient is telling you that they've experienced, symptoms, past medical history, all of that stuff is subjective data. Objective data is vital signs and the actual physical exam. All right, and this just kind of keys in on what I said in the previous slide, differentiating subjective and objective data. Now, the physical exam doesn't need to be complicated, but for me, I incorporate all of my senses in my physicals and my evaluations of my patients. You need to have technical skills so that you can know how to use the equipment that you may be using, a knowledge of what potential tests that you should be performing on this patient, critical thinking, uh, and identifying things that may present as an opportunity. So if a patient comes in, perhaps they are in for something totally different, but you see they've smoked. Always ask them at their visit, are you still smoking? And this is a big deal. Um, you don't want to be judgmental to these patients. It will shut them off immediately. So, are you still smoking? Okay. Well, if you're ever interested in stopping, let me know. I can help you with that. Um, so, patient might be there for an unrelated issue, but take an opportunity to see, hey, you know what? You are missing a vaccination. You should have gotten your shingles vaccine at this stage. Or, you're due for a mammogram. So always take that because you don't know. Children, most parents are really good about making sure that the student, that their child goes for their physical exams, and in the beginning they're really, really close together, right? And then they space out over time. Well, once you get to adulthood, there are many, many, many patients who only go to the doctor or nurse practitioner when they're sick. So we have to grasp onto any opportunity that we can to ensure that preventative health care, like colonoscopies and mammograms and vaccines, are being addressed. All right. Precautions. we need to identify if our patient has a latex allergy. Now, most healthcare facilities don't use latex anything anymore. But it's good to know when you're setting, when you're doing your practicums or when you get a position, there still might be some latex catheters out there. Um, so ensure, that you know what's what. Some people can have severe allergic reactions to latex, all the way up to anaphylaxis. And healthcare workers, because of their repeat exposure to latex in the past, were at great risk of developing this because it's repeated exposure that increases the risk. All right, so I begin observing my patients from the time I call them into the office till the time they walk out of the office. So I am observing things and I'm looking at how they were sitting in the waiting room, their gait, does it look like they're guarding anything? Um, how's their color? Do they look lethargic? All of those things. That's my first. I start the minute I lay eyes on that patient, maybe even sooner, because I always review my charts before I call the patient in so I can have an understanding of some of the patient history. You want to ensure that you provide the patient privacy and that there's adequate lighting, but it isn't too bright. Big thing, never act hurried. If you are hurried because you have 15 patients waiting to be seen in the waiting room, you might feel anxious on the inside, but you cannot express that on the outside. You can't say, oh my gosh, we're so busy today. No, keep it in the inside. For that 15 or 20 minutes that you're with that patient, that is that your patient's time, and you need to um, give to them your whole attention. When you're exposing a patient, just expose what you want to inspect, validate findings with the patient. Now, I've gotten into the habit over the last few years, I didn't always do this, but when I'm going to examine the stomach or I'm going to examine the back or even listen to lung sounds, I ask the patient, is it okay if I lift up your shirt? Or can you push your leggings down so that I can take a peek at your stomach? Is that okay? Um, I always ask permission. This way, the patient feels a little bit of empowerment, and we're just not ripping their shirt off. We're going to validate findings with the patient. If the patient is experiencing abdominal pain and I hit the spot, I'm going to say, is this where the pain response is coming from? The patient will say yes. And then, of course, there are other techniques. I really want, when it comes to pain, I want to know what the characteristics of that pain is. And down the road, I have a really great video on pain and finding out if it's visceral pain or, I mean, it can really, really help you to identify the cause of the patient's issue. So I want to know some characteristics of the pain. Is it throbbing? Is it constant? Is it stabbing, sharp, dull, intermittent? Um, all right, and the patient can be placed in lots of different positions. I want to do what makes the patient most comfortable while providing me the ability to perform the examination that I need to perform. I've never done, well, I guess maybe I have done a prone checking out hip. Now, the sequence of your physical exam. You probably know this from your undergrad, but it's inspection. Always look first, look, feel, percuss, and then auscultate. So we want to look first, palp second, percuss, and auscultate. And I know that that's a question that's going to be on your certification exam down the road. So make sure that you are really confident in knowing what those things are. Now, there are exceptions. Children. I'm going to perform my exam in a way that is going to be the least disruptive to the child. I'm going to do the least invasive things first and do the most invasive things last. Now, if you are assessing all body systems, you want to follow the sequence that is going to follow the most sense. For me, it's usually head to toe. That's just me. But there may be other methods that make more sense to you. I like to work my way from the head down, and I do that when I do my physical exams. Once I've gotten heart, lungs out of the way, I do head and then work my way down. Inspection, we spoke of this earlier, begins with the first interactions with the patient. And this can actually reveal a lot about the patient. When you're inspecting, you want to look at the color, size, movement, texture, symmetry, any odors, any sounds. Compare the left to the right always. You might, in a case like this, you might use your otoscope, ophthalmoscope, pen light, perhaps nasal and vaginal speculum to enhance your view, whatever you need to do. And if the patient comes in and says, I have right ear pain, okay, I always look at both ears. You're never just going to look at the ear that hurts, because believe it or not, I have had some patients come in that complain of right ear pain when it is indeed their left ear that is causing them the discomfort. Something in their wiring is making the other ear hurt. Your inspection should be concentrated observation. Use your vision, sense, and hearing. Smell too. And again, you may need to use an ophthalmoscope, otoscope, pen light. There are other tools that you may need to do to enhance your inspection. Palpation. The use of hands and fingers to gather information through the sense of touch. And sometimes we palpate using the palmar surfaces of our fingers and finger pads, ulnar surfaces for vibration, and dorsal surfaces for temperature. So I'm actually going to feel the back with the back of my hand sometimes too. We start from mild palpation to more firm palpation. And when we're doing this, I'm looking for any fluid, crepitus, mass, or any structure that I may feel with my hands. And remember, you start with light and move to deep. With palpation, I also want to note the feeling. So what does the texture feel like? Is it rough or smooth on skin? I might do this with a rash. Is the rash rough or smooth? Temperature. If they have a wound, is it warm, hot, or cold? Moisture. Dry, wet, or moist. Again, this could be a wound. Motion. Is it still or vibrating? The consistency or structure. Is what I'm feeling mass? Does it feel solid or does it feel like it might be fluid filled? You can tell a difference. Solid, it feels like a rock. It's real hard. Fluid filled are more squishy and spongy. And does the pain elicit any pain response when you are doing your examination? Percussion. This is an act of producing vibration and sound waves to produce percussive tones. You strike one object against another by tapping your fingers or hands quickly and sharply against the part of the body. It produces a sound that's going to help you determine the location and size, density of organs as well. So we use this to determine the size of the liver or the size of the spleen. This is also used to identify organ shape, position, if an organ is solid filled or fluid filled or gas filled, because you'll get a different tone with your percussion. You percuss over a gassy tummy, and it sounds like a tympanic drum. So you will get different sounds dependent. Fluid filled is a dull. The degree of tone is determined by the density of the medium through which the sound is traveling. So direct percussion, the striking of a hand, directly contacts the body, which elicits info about tenderness. Like the sinuses, I do this all the time. I always, if a patient's coming in complaining of sinus symptoms. Indirect percussion uses both hands. It produces sounds that gives you clues about the underlying makeup to tissue. And a stationary hand uses a hyperextended middle finger, and we place the distal portion firmly against the body part. So when you're doing percussion, the finger is going to strike against the body. You usually use your striking hand is your dominant hand, and then your fist, use your dominant hand placed on the body part to strike. And I always use my middle finger. I use the first joint of my middle finger and tap that on I tap that joint to elicit my response. Percussion. The vibrations penetrate about 5 centimeters deep. So deeper mass would give no change in percussion, so eliciting pain if an underlying structure is inflamed, like an appendicitis or a peritonitis. Eliciting a deep tendon reflux using percussion hammer is something that we do for patients when we're monitoring reflexes. And that's also an example of percussion. Tapping a person's skin with short, sharp strokes to assess the underlying structure. We talked about this, mapping the size of organs, the density of organs, and all about percussion. And I'm going to ensure that you have some really good, and I picked these all out myself, so I think they're good, videotapes or videos. Oh, how old am I? DVDs that illustrate these techniques. The tones that you're going to hear, timpani, that's what I talked about. It's loud, high, drum-like. You'll see that in a gastric bubble. We used to do that back in the day when I worked in women's health to check feeding tubes in babies. Hyperresonance is very loud, booming, and you'll get this with patients who have emphysema. They have air trapping. Resonance, loud, low, hollow, that signifies healthy lung tissue. Dullness, over the liver. Flatness, over muscle. So I want you to try to do these examination techniques on yourself and on family members so that you can be introduced to it. We've got a video here of a percussion illustration. Auscultation. It's listening to the sounds produced by the body. We use a stethoscope to listen to breath, heart, and bowel sounds. And I really believe that you should invest in a high quality stethoscope. I like Littmann. You know, I wouldn't waste my money on an electronic stethoscope because I only did because my workplace pays for a stethoscope. And it seems so cool. But it doesn't really work well on lung sounds. Heart's okay. I much prefer the Littmann, but invest in a really good stethoscope. So most of them have a diaphragm and a bell. The diaphragm is used for high-pitched sounds like breath and bowel sounds and heart sounds. The bell is best for low-pitched sounds like an extra heart sound or murmur. Different techniques of listening to the sounds of the body. Place the stethoscope on bare skin, not over clothing. I see, oh my gosh, it makes me cringe when I see providers do that. You are not gathering a clear picture of what's going on if you're listening over a shirt. Try to have the room as quiet as possible. It seems like everywhere I go, kids are listening to their parents' iPhones to keep them occupied. No videos going on in my examination room. It's distracting for me. It's distracting for the patient. They can wait 15 minutes to get back to their YouTube video. Place a stethoscope on bare skin. Listen for the intensity, pitch, and the duration, also the quality. Concentrate on one sound at a time. So if you're listening to the heart and the lub-dub, lub-dub, I'm focusing on that lub first, and then I'll listen to the other. For auscultation, position the earpieces towards your nose, hold the diaphragm firmly against the skin. Hold the bell lightly against the skin, just enough to form a seal. So when you're looking for those murmurs and extra beats, and you're using the bell, which isn't all that often, right? Just a light seal. You don't need to push firmly. And always remember the patient's comfort. Necklaces in the way can cause confusing sounds. Of course, as I said before, friction from body hair, also telephones, and anything that's making a noise around you. Jewelry is a big one. Like if they have a necklace on, I might hear something that I didn't, that really is insignificant. So when we are doing our examination of our patients, we always want to consider the emotional state. Are they anxious? Are they nervous because we're a stranger? They don't know what's going on with them, so they're scared. I want to try to reduce that anxiety to make them feel more comfortable. So as I said in my last video, I always introduce myself if I walk in the room or if I call the patient to the room in a very comfortable manner. I say, hi, and I state their first name. Hi, Susan. My name's April. I'm the nurse practitioner. How can we help you today? And then I sit down with them, I face them. I always have a notepad with me to take notes because I don't believe in documenting while you're interviewing your patient, but a lot of people do it. It's just my personal thing. I'm very fast on the computer. I have a lot of pre-made notes. So if everything meets a certain criteria, all I have to do is push a button in my electronic medical record. So it's very easy for me because I have such an easy way to set up notes, and we use Epic, and you can customize Epic. So I have a preset for sinusitis. I have a preset for strep. I have a preset for urinary tract infection. And so then all I have to do is push the button. And if there are any variances, I can go in and correct those, and that just takes a second. If not, I just push a button and it's done. So talk to the patient face to face. The hands-on portion for sure is going to be the vital signs. You may or may not have a medical assistant who does this. Sometimes I do, and sometimes I don't. I really appreciate when I do, but if I don't, while I'm doing the vital signs, I'm talking to the patient, so there is no time wasted. We want to make sure that we are focused on one step at a time and the examination sequence. Health teaching, when findings are complicated, and summarize findings for the person. I've had some cases that were complicated, and sometimes I need to tell the patient, you know, let me step out. I want to look at something, and then I'll be back. So sometimes I will go into my other office and I will look up references, resources, um, drug interactions. I don't want to do that in front of the patient, although now with smartphones, many people do. I don't like it myself because it, I don't know, it just makes me feel like I'm projecting that I don't know, which I really don't, but I don't want to project that. So I'll go in the other room. Not everybody has the ability to do that either. And maybe patients are getting more comfortable with providers looking at their cell phones on apps. That could be, but I guess I'm just not there yet. Patients with mobility impairment and disabilities, I have to consider this. If I have an elderly patient in a walker or a wheelchair, am I going to be able to get them up on the exam table? Maybe not. Can I conduct the examination in their chair? Sure, I've done it many times. Spinal cord disabilities, this isn't something I interact with often. I do occasionally, but rare. Um, and bowel and bladder concerns, autonomic hyperreflexia. So, a lot of things that you would consider with these patients. Patients with sensory impairment, if they have impaired vision, we want to identify ourselves clearly, orient the patient to the surroundings, um, help them with any canes or guide animals. If they are hearing impaired, it is our duty to provide interpretation services for them. And I'm so lucky because, as I said in the video yesterday, we have such an excellent interpreter line, and it also has sign language. So we can call a sign language interpreter for our patients, which is just fabulous. With height and weight measurements, adults standing on a platform scale, we usually use electronic scales. I don't see the old ones being used anywhere. And a child, when they're able to stand, I'll measure them there. But we also have platform scales and tape measures in the event that we need to assess height and weight that way. But I I find that most, if they're walking, they'll stand on that scale because we need to know the weights of all of our kiddos because all medications in the pediatric population are determined through weight. So we need to know their weight. With adults, I'm less concerned about that, but some providers are just adamant about getting a weight on every adult patient that comes into the clinic. Now, of course, if they're for a physical, absolutely. If they're there for strep's throat, for me, it's not a priority, but for lots of nurse practitioners, it is. When you're in practicum, you want to embrace the practice of the people you're working with, so follow their lead. Don't say to them, well, I want to weigh the patient if they don't weigh the patient. Just go with the flow and see how they practice. The thermometer, again, I'm old school. Gosh, it's just ridiculous. But I use the oral thermometers, the electronic oral thermometers. Um, we have a lot of different ones now. We have the infrared thermometer, we have the temple thermometer, but in infants, rectal temperature is always preferred up to 3 months of age because of its accuracy. Why do I like oral? Well, I've had this happen to me multiple times. That's why I changed my practice to only use the oral. Medical assistant took the temperature of the child using either the sensory or the temporal, and I come in to examine the child. They feel as hot as heck, and I take an oral temperature, and it's over 102. The other two did not elicit a temperature at all. So after that happened to me about 3 times, now I requested of my medical assistants only oral temps, and I also, when I don't have a medical assistant, oral temps for me. But again, adopt the practice that they are using in the setting. The stethoscope, there are 4 types of amplification that we're looking for: acoustic, stereophonic, magnetic, and electronic. We want to stabilize the stethoscope between the fingers, the diaphragm, press firmly against the skin, and the bell place evenly and lightly on the skin. I don't know why this slide did that already. Blood pressure cuff. The biggest thing, I mean, I'm sure that you all have taken a zillion blood pressures in your life, okay? Most places use electronic sphygmomanometers. We don't. We use the old-fashioned cuff. And the old-fashioned cuff is actually the most accurate. This is something that I'm not, I guess if I were working in a cardiologist's office where my focus was blood pressure instead of an acute care setting, I'd be more focused on sphygmomanometer, but I'm really not, except in the size of the cuff. You have to use the right size of cuff for the patient's arm. And there's a ton, all the way from infant to, we use a thigh cuff on morbidly obese patients. Because you will definitely, if you're using too small a cuff, I've had it be quite striking actually that their blood pressure is so much higher than it actually is by using the wrong cuff. So always try another cuff. In my setting, if a patient has an elevated blood pressure, if it's super high, like 220 over 130, I'm going to send them, I'm going to advise them to go to the emergency department for evaluation. But I just don't say, oh my gosh, your blood pressure is too high, you need to go to the ED. I will do both arms. I'll have them sit in a chair with their feet on the ground, not crossed. I will have their arm at level with their heart. I will give them time to relax because white coat syndrome is a real thing. And there are some people who have perfect blood pressure. They come into the clinic and bam, it's going to be high. So I always ask them that. And a lot of patients have an electronic sphygmomanometer at home, so they take their blood pressure. So if I get a high blood pressure and the patient says, I take it all the time at home, it's never over blank d blank, and they do not have a diagnosis of high blood pressure, I will add the diagnosis of elevated blood pressure reading without the diagnosis of hypertension. That is an ICD code. So that it's obvious that I've addressed it. I also will make sure that the chart gets sent to their physician if they have one. Luckily, I have a little thing. All I have to do is push a button and the whole chart gets sent to the physician's inbox. I did that yesterday, and it's so nice when the physicians recognize it. I had a patient who came in, she was 6 weeks pregnant, and she had strep throat and was allergic to amoxicillin. I know amoxicillin is super safe in pregnancy. I didn't really want to use Zithromax, even though it said that it was safe. There was also an addendum on there that said that there was an increased risk of miscarriage and abortion. So how can that be? So no, I'm not doing that. So I decided on Keflex, but you know that there is a 20% crossover in allergy to patients who are allergic to penicillin are also allergic to cephalosporins. Now, this patient did not have an anaphylactic reaction with penicillin, so that gave me the go-ahead to order Keflex. And I sent the chart to her OB-GYN, and the OB-GYN sent me an email back. Thank you so much for keeping me updated. And I thought that was nice because most of them. Pulse oximeter measures the percentage of hemoglobin saturated with oxygen. When we have patients in our office, if you're doing primary care, okay, if you're in the hospital or if you're in an urgent care, you're really not focusing on these things. But if you're in primary care, only do a pulse oximeter if it's indicated because the patient is going to get billed for these services. So if I have a patient that comes in and they are short of breath, they've got a cough, they have asthma, bronchitis, absolutely. But if they come in and they have a splinter in their toe, no, I'm not doing it because they'll get charged for it. Doppler, I don't use these, but a lot of places do. Um, Ultrasonic stethoscopes, they use them a lot to detect blood flow and pulses. If a patient has pulses in their feet, if they're experiencing, oh gosh, I wanted to say retinopathy. What am I talking about? You know, where they can't feel their feet, myopathy. Um, a portable ultrasound, again, this is not something that I use. You'll see this in some clinics. Some offices actually have portable ultrasounds as well, but a lot of ultrasounds in the emergency department. Fetal monitoring, if you're working in women's health, you'll be using fetal monitoring and Dopplers to determine the fetal heart rate. Nobody uses a fetoscope anymore. Nobody uses a stethoscope to hear fetal heart rate. It doesn't work. And a left scope, I have to tell you, I don't know what that is. Never heard of it. Okay, I have to say that of all of the skills that you're going to learn, mastery of an ophthalmoscope is probably one of the most difficult. I don't use it all that much in my practice because I'm in acute care. I do sometimes if I have a head injury, or someone coming in with elevated blood pressure or high sugars, but it allows us to see the inner eye, and we can see all of the vessels in there, the fossa ovale. I mean, so many things that we can see in the inner eye, that can give us clues as to the health of the patient, especially for diabetics and especially for hypertensive patients. Vision charts. This is the Snellen chart, and we use this in our physicals to identify. It doesn't replace going to the eye doctor, but it does help give us an idea. A big thing, big important thing, is that in order for a child to participate in sports, they have to have no less than 20/40 vision with glasses. If they do not have 20/40 vision with glasses, we have to get them there or they can't participate. That is from the Blue Book, which is by the American Academy of Pediatrics, and they are the gold standard of everything peds, including sports physicals. There's another one that has shapes on it for little ones who don't know their letters yet. Next is the otoscope. Next to my stethoscope, this is what I use most often. And I use it for looking in the ears. I also look in the eyes, mouth, up the nose. Um, I use it all the time. And you should have a little pump attached to it. It looks like a little tube that's got a bulb on it. And uh, especially in pediatric patients, when I'm looking in the ear, I will compress the little pump to look and see how their eardrum moves. It should be nice and brisk, moving back and forth. If it isn't, that can indicate that they're having some issues with fluid in their middle ear. Tuning forks, we'll use this to identify hearing loss. Um, and I don't use these a lot, um, but if you were doing a complete physical on someone, I can see where you could use them. It detects auditory function and vibratory sensation, and you can indicate it. Um, you can note the loss by using these tuning forks. In young children, they don't work so good. Other things that aren't shown here are percussion hammers and a neurologic hammer, which measures sensory perception. So, um, all things that you need to consider having in your toolkit. A tape measure. I use this a lot. Um, if someone comes in with a wound or a rash, I want to measure it so that we can keep track of the size of it. And so I will look to see and measure it. A transilluminator, that's a strong light to distinguish whether a body cavity contains fluid, air, or tissue. You'll do this in some patients with a swollen testicle or a lump in their testicle. If you shine that light on the testicle and it shows through, it is determined not to be a solid mass. It's fluid. So we use that sometimes. The vaginal speculum, I don't do vaginal exams in my setting, but lots of urgent cares do, lots of emergency departments do, and in women's health, you do them all the time. There is a whole bunch of different ones. 2 blades and a handle. There's, I think you're going to find most commonly used are the disposable ones that you'll see. I think those are used most often in practice. The one time you might want to use a regular speculum is if you have a morbidly obese patient, because it helps to hold the walls of the vagina in place. So you might want to do that. Goniometer, it determines the degree of joint flexion and extension. 2 straight arms that intersect and can be angled and rotated around a protractor. So this is really good for someone who works in orthopedics. So you can measure the degree of extension and flexion. They use this a lot in physical therapy so that they can determine progress. A Woods lamp. This is a source of light that will help you identify certain conditions. Okay, so let's first talk about an eye. If somebody has, and it's a black light. This Woods lamp is a black light. If someone has a scratch of the cornea of their eye, you're going to take this bright neon yellow substance, which is called fluorescein, and you will place it on the eye, and it is going to stain the eye yellow. You'll take this Woods lamp or the black light and shine it into the eye, and you'll be able to see the corneal abrasion because it will light up. So this is something you'll do if the patient comes in with an eye irritation but doesn't like fit your classic conjunctivitis. I want to rule out that they don't have a corneal abrasion. We also use it to determine the presence of fungi, bacteria, and pigment changes, skin lesions. Some skin fungi grow yellow-green, so we might be able to identify a glow. Monofilament, you use this in your diabetic patients, and this is a test for a loss of protective sensation, particularly on the foot. This is, it's kind of like a stick that has this plastic monofilament attached to it. And there is a process that you're supposed to go through by touching different areas of the foot and asking the patient when they are not looking if they can feel what you're doing, if they can feel it. So this is something that should be done on all of your diabetic patients. Some research or some literature supports doing it at every visit. So this is definitely something you're going to be doing on your patients, your diabetic patients for sure. Scoliometer. I have one of these because I do a lot of sports physicals, and it measures the degree of rotation of the spine. Patient's going to bend forward slowly, stopping when the shoulders are level with the hip. And I'm going to place this meter on their back, and it's actually like a little lever or a level. It will tell me the degree of curvature. and it's considered positive if the reading is 7 degrees or more, and then I would refer that patient off to orthopedics. So I hope that this presentation gave you some guidance and some tips about the tools that you'll be using in your physical assessments and gave you a little bit of confidence. So good luck and have a good rest of your day.